Okay, so when we say the peptic ulcers means the ulcers which are present, which are developed in the effect of in the presence of the acid and pepsin. Means there must be a gastric mucosa involved. There must be a gastrin secretions must be there, acid secretions must be there for the development of the peptic ulcers. In general, these peptic ulcers are developed in two areas. First, in the stomach and in the duodenum. So we have so many classifications. We means to discuss these things. We classified in various means in the parts. First, we discuss in the acute and chronic ulcers. Then we discuss one by one. First, the gastric ulcers, and then the duodenal ulcers. So when we say acute ulcer, acute means when the ulcers are present very early with due to recently any patient has suffered recently any etiological factors, the patient has taken some medicines or patient has undergone some particular conditions so that the patient has developed the ulcers and the history is very short time, while the patient give the long time history and repetitive attacks are there, then we call it chronic. So now we discuss that site of the peptic ulcers. So already we know that the peptic ulcers are present are included the ulcers which are present in the stomach as well as in the duodenum. So in the stomach, the most common site for the development of the ulcers is the lesser curvature. You can see this lesser, and in the duodenum the most common site is this first part of the duodenum, though ulcer can be present in the other areas also, but the commoner site in the stomach is the lesser curvature, and in the common site the duodenum is the first part of the duodenum. The other lesser common site are lesser common site are the esophagogastric junctions, means this junction where the esophagus has just joined with the stomach. That site is also very important. So many ulcers are maybe there after the esophagitis, and the body of the stomach is also a part where the ulcers can be developed in the greater curvature, and the other part of the duodenum, some part of the duodenum is also we discuss one later that some percentage means 5%, 10% ulcers may be present in the second and third part of the duodenum, and sometimes in the Meckel's diverticulum also, because Meckel's diverticulum contains the gastric mucosa. That's why the ulcers may be present in the Meckel's diverticulum inside also. So now we discuss the acute peptic ulcers, how they developed. The commonest cause for the development of the acute peptic ulcer is the inhalation of the medicines which has tendency to damage the gastric mucosa, or which damage this mucosal barrier, so that the ulcers are developed. So these medicines are the NSAIDs, non-steroidal anti-inflammatory drugs. So these drugs are the most common factor for the development of these acute peptic ulcers. Beside the acute peptic, these drugs, the patients recently have the hypovolemic shock, or that hypovolemic shock may be due to the severe injury or say other any particular other conditions. Patient suffering the burn, a third-degree large area burn. So that's why the patient going into the hypovolemic shock for longer period. So when the gastric mucosa underwent the hypovolemic stage for the longer time, then it's the mucosal layer is get damaged, and the ulcers may be present there. So that when the gastric mucosa undergoes in the hypovolemic stage for the longer time, then there is the inflammation occurs called the stress gastritis. So that stress gastritis leads to the stress ulcers in the stomach. The other factors when the patient suffers long-term sepsis, long-term patient suffers long-term severe illness. So in that conditions, the ulcers may be present. And the patients having cerebral trauma or neurological disorders. So in that case, the ulcers that cause the Cushing ulcers. And similarly, the burn patients may have this ulcer called the curling ulcers, or the patient receive steroids that may also develop the ulcers that called the steroidal ulcers. So these are the different drugs or different particular conditions which may cause the development of the ulcer in the gastric as well as in the duodenal part. So these acute peptic ulcers, these are called the acute peptic ulcers because they don't have very long history. The patient usually give the recent history of any of these factors. Now we discuss the chronic ulcers. So in the chronic ulcers, first the duodenal ulcers. As we say, the acute ulcers are rare in duodenum. Usually the chronic ulcers are present in the duodenum. Acute ulcers are more commonly present in the stomach only. The feature of the acute duodenal ulcer are similar to the acute. We already had discussed the features of this duodenal ulcers, acute duodenal ulcer and acute vessels are almost similar, and no particular characteristic features are there. In the duodenal ulcer, we talk about the duodenal ulcer. 85% of duodenal ulcer are present in the first part of the duodenum, means the 2 centimeter away from the duodenal and the stomach junctions. 10% the next 3 centimeter, 5% in the ampulla of Bader. The average size of the ulcers present in the duodenum is 1 centimeter diameter, and they may have the different shapes: oval, circular, eccentric, or sometimes pear shape or triangular ulcers. Usually the ulcers are having punched out appearance. Punched out means the the margins of wounds are sharp and deep, and sometimes the overhanging margins may be there, and the base of these ulcers are usually covered with the this yellow color mucopurulent debris, this dead yellow color tissue. That is the feature of the duodenal ulcers. And one more important features in the duodenal ulcers we must to discuss. Usually the duodenal ulcers are present in either in the anterior wall or in the posterior wall. But in few cases, the ulcers may be present in both anterior and posterior wall. So that cases the ulcers called the kissing ulcers, because of both ulcers at the edges or margin of the both ulcers can touch to each other, because the ulcers are present in both anterior and posterior wall. And why we discuss there, because it is very important. If the ulcers are present in the posterior wall, that ulcers has more tendency to cause the severe hemorrhage in later stage, because of the presence of this gastroduodenal artery just behind the posterior wall. While the anterior duodenal ulcers are more tends to be perforate in later conditions. If in chronic stage, than the bleeding. So if the ulcer is duodenal ulcer is perforate, then more chance to it should be present in the anterior wall, and if the duodenal ulcer is bleeding, then there is a more chance it should be in the posterior wall. And if the ulcer are present in both anterior and posterior wall, then after the healing, then there is a lot of chance that the scarring will be there that can reduce the lumen of the duodenum, and that may cause the pyloric stenosis in later conditions. The etiological factor behind the duodenal ulcer is the acid hypersecretions, genetic predisposition, and endocrine dysfunctions may be there. Patients suffering from liver disease for longer durations, patient with the emotional disturbance. These all things disturb the acid secretions in the stomach, and that causes the uh, development of the this duodenal ulcers. Patient having very fried and spicy diet, patient who smoke or having the H. pylori infections, that conditions are favorable for the development of the duodenal ulcers. Now we discuss the gastric ulcer. So the common site of the gastric ulcer, we all know that lesser curvature, while it may present in the greater curvature, the body and the antrum also. So, but the most common site is the 80 to 85% in the lesser curvature, 10% the antrum, 2% pylorus, 3% the cardia side, and 5% the fundus and body. The difference between gastric ulcer and duodenal ulcer is that duodenal ulcer are usually shallow, but the gastric ulcers are big and deep, and the large areas are involved. Here, the most common factor for the development of the gastric ulcer is that first the using of the NSAIDs, and second having infection of the H. pylori. Incidence of the gastric ulcer is same in both sexes, male and female, but the elderly persons, it's more common the elderly persons with the lower socioeconomic status. They say that gastric ulcers is inversely proportional to the status of the socio-economic status of the person. The person with a high socioeconomic status have low chance of development of the gastric ulcer, while the patient with a low socioeconomic status have high chance of development of the gastric ulcer. The etiological factors, mostly the factors are the same for the development of the gastric ulcers, but here the diminished mucosal resistance, that is the important factor that may be due to the taking of the different medicine, the hormonal effects or some other factors may be there. Pyloroduodenal reflex is the important factor when the content from the pylorus comes with the stomach, and that damages the mucosal barrier and causes the gastric ulcers. Mucosal trauma, local ischemia, H. pylori infection, antral stasis, and the NSAID overuse. This is the most important factor. That's why if you ever prescribe NSAID to any patient, you must give some anti-secretory drugs along with that PPI or H2 blocker to protect the gastric mucosa to avoid development of these gastric ulcers. Clinical feature of the peptic ulcers: the pain is these are the 5 characteristic features in the patient of the gastric ulcers. Out of the pain, periodicity, vomiting, alteration in weight, and bleeding. The pain is not very severe, and pain is also associated with the food. Means in the gastric ulcers, patient the pain start just after the taking meal, while in the duodenal ulcer, pain start after the 2 to 2.5 hours of the taking meal. So there is a typical pain. Pain is uh, not colicky in nature. Pain is continuous and agonizing pain in the upper abdomen, especially in the epigastrium region. And the pain relieving factor and aggravating factor are different in the gastric as in duodenal ulcers. In the gastric ulcer, the vomiting, if the patient vomit, that the patient feels a relief. While in the duodenal ulcer, if the patient take food, then patient getting relief. So the pain is associated with the food also, food in both, but that in different ways. Periodicity is the factor which is associated with the duodenal ulcer more, as the patients with the duodenal ulcer have a characteristic feature of the periodicity. Periodicity means the patient have few months or few weeks with this pain and all these features, then suddenly all the symptoms gone and patients have symptom free weeks or the month. Few weeks, a few months, patient feels nothing, patient feels that every symptoms resolve itself, but again after few months or few weeks, symptoms again appear and patient feels again sick. So that the characteristic periodicity is nature, uh, periodicity nature is present in the factor of the duodenal. Vomiting is always not a very important factor associated with the peptic ulcers. Till then, there is a scarring or there is any obstructions in the due to the duodenal ulcer or gastric ulcers. Till then, vomiting is not regular features. But some patient of the gastric ulcers, when they vomit, they feel the relief. So, in the gastric ulcers, patients feels of the patient feel better after the vomiting. So, in that case, vomiting may be there. But in the duodenal ulcer, vomiting is not there. Till then, there is a scarring and there is a obstruction in the pylorus. Till then, vomiting is not associated with the duodenal ulcers. Alteration in the weight is also important. Most of the patients with the peptic ulcers have the long time history of the loss of weight, because patient is not able to assimilate whatever the food he or she is taking, so proper digestion is not there. In that case, most of the gastric, especially the gastric ulcers patient, will give the history of the loss, weight loss, while the few patients with the duodenal ulcers may give the history of the weight gain, because the patient with the duodenal ulcers feel better when the patient eats. That's why patients eats regularly and gets the weight gain may be there. And so that in duodenal ulcer patient may have the history of the weight gain also. And bleeding is also important, though patients bleeding from the gastric ulcers usually present with the hematemesis, while the patient bleeding from the duodenal ulcers present with the melena. That's why if you're suspecting patient duodenal ulcer, then must do the stool examination so that you can find the RBCs in the stools. Now we have a comparison between acute and chronic ulcers. So, as the name suggests, acute ulcers usually have presence shorter durations, while the chronic must give the long time history, more than 3 months, 6 months. Patient with acute having slight attack of dyspepsia means only little nausea and indigestion and vomiting, while the patient with a chronic peptic ulcer have long history of the dyspepsia. Patient with acute ulcer may cause hematemesis in both sexes at any age, may perforate, especially if in the wall of the duodenum, and may progress into the chronicity. While the chronic patients, the gastric ulcer is aggravated by the food intake. Duodenal ulcers after present of the 3.5 hours of food intake, that's why it's called the hunger pain, and patient relief by taking food in case of the gastric ulcers, chronic gastric ulcers. Here is the comparison of the gastric ulcer and duodenal ulcers. Most of the things we already had discussed, but just to recap this one by one. If we see the age, then the gastric ulcers, patient with the gastric ulcer is usually middle age, while the duodenal ulcer is usually young age patients. Gastric ulcers is more common in the males than in females, while duodenal ulcers males dominate but not as gastric ulcers. Means dominance is not as much as the gastric ulcers. Constitution of the patient with the gastric ulcer usually lean and thin, and patient is anemic, while the duodenal ulcers are patient with the duodenal ulcer usually looks very healthy. Periodicity is less marked. Attack lasts several weeks and then freedom from system 2 to 6 months. While the periodicity is more marked and more characteristic in the with the duodenal ulcers, patients have the attack for several weeks and then freedom from the system for 2 to 6 months may be there. When there is no symptom, patient is absolutely fine. If we talk about the pain, the gastric ulcer pains have the region in the mid-epigastric regions immediately after taking food and relieved by vomiting, not felt in the night. While the pain in the duodenal ulcers is severe and is spasmodic in nature. The area is the transpyloric plane. Start 2.5 to 3 hours after food. That's why it's called the hunger pain, and food relieved. And when the patient take the food, then pain is relieved. And the pain in the duodenal ulcer is usually present in the midnight or late night. Vomiting is the marked notable symptoms. Patient feels the relief of the vomiting, so that's associated with the gastric ulcers. Vomiting is a rarely notable symptoms in the duodenal ulcers because until unless the pyloric stenosis is there. So regurgitation of the food occurs that may cause the heartburn in the case of the duodenal ulcers. Appetite of the gastric ulcer patient is usually good, while the appetite with the duodenal ulcer is also good, and patient eats frequently to avoid pain because to avoid the hunger pain. Patient with the gastric ulcers is in the long time patient afraid to take food because whenever the patient take food, the pain starts. While in the duodenal ulcer, patient love to take food because when the patient his stomach is empty, then the pain start. That's why patients continuously try to eat. Hemorrhage is less common. Hematemesis is common in that. Then melena in gastric ulcer, while the patient with a duodenal ulcer, if the hemorrhage occurs, then melena is more common than hematemesis. On examination, you may find the tenderness over mid-epigastric region in the patient with the gastric ulcers, while then the duodenal ulcers, you may find the tenderness in the transpyloric vein, 1 inch right to the midline in case of the duodenal ulcers. The investigation technique to diagnose this peptic ulcers. So usually the patient with the peptic ulcers you may diagnose easily with the history and the physical examinations only, because the characteristic periodicity, pain, vomiting, and relieving aggravating factors, patient's constitutions, all that things. But if you need to examine if you need to investigate, you need the evidence. So in that case, these few investigation techniques are very much useful to know to find the exact management. The one and most commonly used nowadays is the flexible endoscope. The endoscopy is the technique when we directly see the gastric mucosa and the duodenal mucosa through the endoscope. Then contrast radiography. In this radiography, contrast radiography means we give the patient some material, some radio opaque material, and then take the X-ray. So that barium enema, barium barium meal, barium swallow through, these things are used to the patient where the endoscope is not available, and where you want to know the if there is any permanent changes in the structure of the duodenum, or the stomach is there, so that may be visible that the filling defect may be present. And ultrasonography, especially the endoluminal ultrasonography, means that the ultrasonography probe is inserted to the esophagus, and then the ultrasonography is done. So that sonography usually useful when you are suspecting the malignancy, and the malignancy is present in intramural malignancy in the wall of the stomach or the duodenum. So in that case, ultrasonography is very much useful. Otherwise, CT is also important if you are suspecting. Though these ultrasonography, CT, and the laparoscopy, these investigations techniques are used only if you are suspecting malignancy post to these peptic ulcer diseases. In that cases, then urease test kit and urease breath test, these two tests are to diagnose, to confirm the presence of the H pylori. So in the urease kit test, the some through endoscopy, some part of the gastric mucosa is taken, and when the no, the characteristic feature of the H pylori is that it converts, it breaks the urea into the ammonia. So when there is H pylori is present, and the urea is there, then it breaks the urea and liberates so many fresh ammonia. So that's by doing this test, if you take the gastric mucosa, and that can contain the pylori, H pylori, and you keep in that packet where where the urea is there, then H pylori converts the urea and liberates the ammonia. So that confirms the presence of the H pylori. Similarly, the breath test is also there in the packet where patient is asked to exhale, and when patient asks exhale in that, so due to presence of that ammonia, uh, this ammonia, the increased concentration of the ammonia indicates the presence of the H pylori in the patient. So these are the few tests to diagnose, to see the particular changes in the gastric as well as the duodenal mucosa. Then these few other investigations, the blood investigations include that the blood counts, and the stool examination that can make indicate the presence of that this RBC that indicates the bleedings, and other we already had discussed. So these are the, you can see these are the duodenal ulcers, this is the gastric ulcers. Now come to the treatment of the peptic ulcers. So three things are there by which you can easily manage the peptic ulcers. First, the lifestyle modifications. Second, the medical therapy, and third, the surgical management. The lifestyle modification means the factors which are responsible for the development of the development of the duodenal these peptic ulcers. That includes the patient having the sedentary lifestyle, means patient not doing the physical work, and just so that obese patient. So in these patients, the chance of the development of the peptic ulcers little more. So ask the patient to mobilize, to do some physical works, so that the reduced chance of the development of these particular conditions. The diet of the patient is also very much important. The patient who take a lot of the spicy and fried food have more chance to develop these peptic ulcer diseases. Patients with irregular food habits, means long time fasting, and then and then repetitive meals. So the patient should take the meals on the time, so that the reflex and the overeating, all these things should be avoided, and the smoking and the alcohol intake. So these are the some factors which are the lifestyle related. If patients follow these instructions, these things, then the chance to avoid these particular conditions. The medical medicines or the medical therapy we discuss in case of this peptic ulcer. The first nowadays the most common drugs used, that is PPI, the proton pump emitters, and the H2 blocker. These two drugs are the anti-secretory drugs. Means if the patient is taking these drugs, then it reduces the secretions of the acid and chance to reduces the secretion, acid secretions in the stomach, and so that the ulcers are not developed. The hyperchlorhydria is avoided, and so that the gastric mucosa is not damaged and the ulcers are not developed. If the ulcer is present, then if you could give these medicines, though, so that the ulcers get the time to heal faster. You know that the gastric mucosa is damaged as faster, it heals also so faster. So you just get the better environment, so that that ulcer heal very fastly. So these drugs, PPI, H2 blockers, and the antacids, these are the symptomatic relief of the hyper acid secretions. Then according to the etiological etiology, if the patient having the H. pylori infections and you confirm the presence of the H. pylori, then you must give the H. pylori eradication therapy. Nowadays, the H. pylori eradication kits comes. That kits contain the three medicines. One, the antibiotics, that clarithromycin. Second, the PPI, omeprazole, and third, the antibiotics, the tinidazole, antiprotozoal drugs. So this is the combination of three drugs: clarithromycin, omeprazole, and tinidazole. And next thing which can reduce the chance of development of this peptic ulcer, that avoid the using the NSAID drugs, avoid, or if you are giving this NSAID to any patient, you must give the PPI along with that, and minimal drugs should be used, minimal NSAID should be used to avoid these particular conditions. And then come to the surgical indications. When surgery is indicated in the patient with the peptic ulcers, surgery is only indicated when the patient fail to respond with this medical therapy. Either patient wants very quick and permanent relief, patient having a long time history, more than 5 years, and there is a repetitive attack pattern, patient fed up that recurrency, or patients having some complications, just like the patient present with the obstruction, patient with the, comes with the hemorrhage, patient comes with the perforations. These are the complication of the peptic ulcers. So if patient comes to with this complication, then we must first go with the surgical intervention to control these things, or patients having previous history of the perforations, or last but not least, if you are suspecting malignancy in any patient, then in that case the surgical indication is there, and you must go the surgical corrections. So in this lecture we just stop here. In the next lecture we discuss what are the surgery proposed for that this peptic ulcer diseases, and what are the other complication and other things.